Hey there. So for this presentation, we're going to be talking about pulmonary rehab, education, symptom control, and some other like surgical interventions. So I forgot to include a joke, so please feel free to look up a joke and have a laugh. But this is gonna be a quick, short, and simple presentation by me, Elizabeth Locker. Okay, so when we're talking about pulmonary rehab is defined as a comprehensive intervention based on thorough patient assessment, followed by patient-tailored therapies that include but are not limited to exercise training, education, self-management intervention aiming at behavior change designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote the long-term adherence to health-enhancing behaviors. Okay, so what does this mean? Well, I got to go to a pulmonary rehab outpatient facility on Tuesday of this week, and it was so much fun because I got to like take the patient's vitals, get to see like where they were on their journey with exercise. So typically how a class would work is each person would, or each client, I guess you could say, would come in. They would get their peak flow meter. Alexa off. Sorry, my Alexa goes off all the time when I'm talking. But they would get their peak flow meter and their incentive spirometer, and they would do 3 peak flows, and we would take the best average of the 3, and then they would do 10 breaths of the incentive spirometer, and we would take, that's one where you take like a nice slow deep breath in, and we would take the best one of the 10. And then from there we do a manual blood pressure, their heart rate, their SpO2, and also just ask them like how they're feeling, and typically from there the patient will go on to either the treadmill, the bike, or they would start with the vest. Usually they wouldn't start with the vest first, but they would go on a piece of exercise equipment, work out for like 15 to 20 minutes, usually at a very like low amount, so like walking, fairly slowly, or whatever their needs are. Then we would ask them to rate their severity of the exercise, 0 or 1 being, super easy and 10 being the hardest. And they would typically rate their severity after that first exercise between like 3 to 5. And then we would get their manual blood pressure again after their first exercise. And then from there, they would do the bike or the vest. The vest was typically 10 minutes. And they would do after they would do the vest, they would usually go on the bike, and then we would do some like education. So this week the education was surrounding allergies and how it's allergy season and when to tell if it's an allergy or an illness. So yeah. Okay, so when it comes to symptom control, we also want to look at like self-management, education, integrative care, and maintenance therapy. So with education, kind of like I mentioned in the last slide, we want to be providing them through like pulmonary rehab or maybe resources given at discharge, when inpatient or when in the hospital. We want to be giving them education that's surrounding smoking cessation, basic information about COPD itself, like what a diagnosis of COPD means, or asthma, or interstitial lung disease, or pulmonary fibrosis, whatever they might be dealing with. And then also aspects of the medication treatment. So like we went over in the last video, helping them understand what is a short-acting beta-2 agonist, what is a long-acting beta-2 agonist, what's the difference between a LABA and a long-acting muscarinic agent, when do they need an inhaled corticosteroid, are they really doing the medication when they're taking it correctly? You know, like depending on what type of inhaler it is, are they, you know, able to really suck in and get the medication if it's like a dry powdered inhaler? You know, if they're you know, using something else to take the medication, are they doing it correctly? I feel like that is a key across the board. And then also, are they using the medication daily? Because a lot of medications aren't rescue medications, right? Like albuterol, the short-acting beta-2 agonist, is a great rescue inhaler. So if a patient is starting to have severe symptoms where they think they're going to have an exacerbation, albuterol can really be great for that, to help alleviate those symptoms. But the majority of medications, especially when we're talking like inhaled corticosteroids, those are maintenance drugs. So majority of the time you really have to use the drug repetitively in order to see any type of long lasting effects. So when it comes to like a combination, right, where we're talking about like a LABA, a LAMA, and an inhaled corticosteroid, right, like the vilanterol and the amycladium and all of those working together to help bronchodilate, open the airways, help decrease that inflammation in the lungs and you know, throughout the body. And then also it gradually working its way up as it's used on a daily basis, that daily regimen. So that is definitely a big factor when it comes to symptom control. I think pulmonary rehab really ties in this one too, because if we're using our muscles, right, and we're strengthening them, it can help alleviate. Like if someone has back pain and they're walking every day, that can help really alleviate those symptoms. So kind of knowing that those things play a factor. I know when it also comes to like cardiac patients, you'll see cardiac patients a lot in conjunction with pulmonology patients, and a lot of times they're not really aware of the severity of like sodium and serving size and sugar intake and how all of those things can play a factor. If I eat a high sugar diet, I'm going to have more inflammation in my body. If I have more inflammation in my body, or I'm eating more foods that are high in histamines, right, that's going to cause an inflammatory reaction, which is also going to infect my lungs, because if my entire body is having an inflammation or an inflammation response, then it's also going to affect how I breathe, and if I snore, and that'll affect my sleep. So all of these things tie together when we talk about symptom control. So when we look at research with oxygen therapy and ventilator support, at least in the research that was provided to us, it seemed like a lot of it was saying that with oxygen therapy, there is long-term administration of oxygen therapy, like greater than 15 hours per day, it can really help increase survival for patients with chronic respiratory failure. Or patients that have like severe resting hypoxemia. So when we think about like, you know, patients that are short of breath all the time with COPD, that kind of live, you know, in that like chronic state where they have the CO2 retention, and then they also have that, you know, decreased oxygen saturation of 88 to 92. And then they're also usually in the 60s, right, on the like hypoxemia scale. When we look at that in research, we can see that patients that have oxygen, especially at home, that really increases their survival. It probably also increases their quality of life. And then when we look at like ventilator supported patients, non-invasive positive pressure ventilation in the hospital setting, can typically help as well to increase survival. On both ends, when we're increasing oxygenation to the tissues, even in patients with, mild to moderate or severe hypoxemia. We're improving their quality of life and also their survival rate or their severity of life. A lot of the research, I feel like, specifically mentioned non-invasive positive pressure ventilation. It didn't really go into, like, at least not the research that I saw, it didn't really go into the survival rate of CPAP versus oxygen therapy, like in the home care setting. I would love to see something like that. I know a lot of COPDers, they'll use, like, especially if they have sleep apnea, they'll use the CPAP at night and then they'll use the oxygen during the day. So I figured that was probably why, is because a lot of times they're used both in conjunction, and they probably didn't have patients that were primarily just using one or the other. But I still found it interesting. Like, I wonder if research could be done just to see, like, long-term wise, which one is more effective overall. I guess it just depends on the issue too, like, or the severity, like if they have a history of heart failure versus someone who doesn't, the CPAP might be more effective, or some type of fluid issue. Yeah, so I guess it also is a case-by-case basis. But the research that we were provided also went into, like, the prescription of supplemental oxygen to COPD patients, and how arterial hypoxemia is defined as a PaO2 less than or equal to 55 millimeters of mercury, or an SaO2 less than 88%, or a PaO2 greater than 55 but less than 60 millimeters of mercury, with right heart failure. We're to prescribe supplemental oxygen and titrate to keep SaO2 greater than or equal to 90%. And then we'll recheck in 60 to 90 days to assess. So when I was reading this, I was also thinking about, like, the 6-minute walk test they do in the hospital. When I was at St. Thomas Midtown recently, I got to kind of see how they'll do the 6-minute walk test, but they'll write down, like, every minute the patient's, like, appearance, SaO2 stat, and then usually also their heart rate, I guess, and then how they were reacting to not having oxygen. And then they were saying that in some situations they have to do the 6-minute walk test twice because insurance, especially like with Medicare, it doesn't always cover the patient to have greater than 6 liters of oxygen in a home care setting. So they have to do the test twice to show that it is really needed. So I found that really interesting. So with surgical interventions, this is not something that we often really see at least I haven't seen in the clinical setting, because it's kind of like a last-ditch effort. Oftentimes, if a patient has severe COPD or interstitial lung disease or pulmonary fibrosis, they usually also have other comorbidities like diabetes, or maybe neuropathy in conjunction with that, or just other factors, maybe heart failure. So typically it's not the chronic obstructive lung disease that may cause them to pass away early, but it's those other comorbidities that just play a major factor. So some of the surgical interventions that I found, specifically in the research provided, was lung transplantation, which is pretty cool. It says that over 1,000 patients with COPD undergo lung transplantation on an annual basis, which is about 30.6% of all patients that undergo transplantation. So you have to think, like, 30%, that's a pretty, big percentage of the overall patients. So COPD definitely plays a factor. And then with lung transplantation, in patients with COPD, sorry, I can't talk today, has been predominantly associated with improving the quality of their life. You have to think it also, really helps them. It helps with hyperinflation and helps them, breathe at a different capacity than what they were at before. The same thing goes for lung volume reduction surgery. So it's, lung hyperinflation. That's a major contributor to impaired respiratory function and is associated with increased hospitalization and mortality. So hyperinflation increases the sensation of breathlessness and causes a reduction in exercise due to increased chest wall elasticity and reduced respiratory muscle and cardiac mechanics. Hyperinflation is most pronounced in those patients with COPD that have an encephalomatosis predominant phenotype. When we think about COPD, right, we have to remember that COPD patients have a diagnosis of both chronic bronchitis and emphysema. And if they have a more emphysematic component, then their alveoli are going to be, really like floppy, right? And typically they also will have hyperinflation, which is like that barrel chest aspect. So like their chest is kind of like almost like puffed out in a sense, or like when someone, works out a lot, but they only work out like their shoulder muscles and they don't work out like the other muscles, or they only work out like their triceps, right? And so it just gives that like big arm effect, but it's not like the entire head of the shoulder. That's kind of what barrel chest is. I don't know if that was a good example, but it's kind of the same component. So those are the two main ones that I could find, was lung transplantation and lung volume reduction surgery. The lung volume reduction surgery seemed really interesting because I've never seen this in the clinical setting. So I definitely would love to like learn more about it, or, see it at another capacity. But yeah, it was really interesting. These last couple of slides are my references. The first slide is more so like links that I used when I was like looking stuff up to, try to get like a fuller picture. I obviously used the pocket guide and the resource that was provided. That was super helpful. So that's majorly what I used most of the information from. But I did look up stuff like on Mayo Clinic and a couple other sites. I included the therapist aid, like coping skills on healthy versus healthy. And then on the second page, I just included some like research articles that I found, like when I was thinking about like long-term oxygen use and like the severity of that use. So if it's easier for you, I can send you the links versus you looking them up this way. But either way, just let me know. Thank you.